Good. Hi, excuse me. Oh, yeah, excuse me. Oui, bonjour. Hi. Hi, how are you? Okay, so now we are presential and we are on Zoom with how many people are online now?
We're 35 right now.
35. Oh, wow. Okay, I think that's very good. So welcome. Okay, I'm very happy to welcome you to that conference. Okay, so thanks for being here. I think we have parents, we have employees, and we have partner. I think that's about it. Okay, so as you know, Giant Steps is now a center. Okay, so we try to evolve, to brings all the competencies, all the knowledge about autism. So we bring higher, and welcome for being here. Okay, I'm a bit nervous now. Thank you. And welcome, Emily. So let's go with you. Thanks.
Hi, everybody. Thank you for joining us today. My name is Emily Curtis. I'm Pedagogical Director at Giant Steps and co-chair for our Research Advisory Committee. Our Giant Steps Living Lab, in partnership with the Canadian Neurodevelopmental Research Training Platform, welcomes you to a special learning series event. The Living Lab is a collaboration between Giant Steps and the TAC Research Network to develop a platform that directly integrates research right here at Giant Steps. As part of the Living Lab, we are excited to host a series of talks with invited experts who present on a variety of topics related to autism, inclusion, education, and intervention, among others. And tonight we have not only Giant Steps professionals, but we also welcome our community of parents and caregivers. And we're excited to have partnered with CanNRT on this event and welcome the CanNRT community, both in person and online. Here to tell you more about CanNRT is Eliana.
Okay, thank you.
Thank you both. Hi, everyone. My name is Eliana, and I'm the Training Program Manager at the Canadian Neurodevelopmental Research Training Platform, what we like to call CanNRT. So CanNRT is a Canada-wide collaborative training environment that supports research excellence and sustainable and equitable pathways for Canadian early career researchers in neurodevelopmental conditions through multidisciplinary cross-sector learning, mentorship, and connectivity. I would like, first of all, to thank Alain, Emily, and the team here at Giant Steps for hosting us here today for this joint CanNRT Research Forum and Giant Steps Living Lab Learning Series. Our research forums serve as a platform to feature members' results and projects and to share and discuss new ideas with expert researchers such as Dr. Kerns, who we're really happy to have with us here today. So before I pass the mic, and I promise it's the last person before you hear from Connor, I would like to introduce you to today's moderator, Gabriella Kennedy, who is a master's student in the Department of Psychology at the Université de Montréal, and who's also a CanNRT fellow. So Gabriella.
Hi, everyone. Thank you for your introduction, Ellie. So our speaker today is Dr. Connor Kerns, Associate Professor in Clinical Psychology and the Director of the Anxiety, Stress, and Autism Program, or ASAP, at the University of British Columbia in Vancouver. Her research focuses on enhancing the functioning and well-being of autistic individuals by improving our ability to detect, prevent, and treat anxiety and stress-related disorders in autistic children. Dr. Kerns has received various funding awards and has presented her findings internationally. She was also recently honored with the UBC Killam Research Prize and has contributed to autism-related public policy in both the US and Canada. Today, Dr. Kerns will discuss the challenges in detecting anxiety in autistic individuals. This talk will highlight the importance of recognizing both traditional and autism-related expressions of anxiety, emphasizing why understanding these variations matter. So if you have any questions, we can wait until the end of her talk and then we can go over them on Zoom or in person. So yes, please join me in welcoming Dr. Kerns.
Hi, everybody. Thank you so much for having me today. I do want to start just with a few disclosures. Here are all the folks who have funded the research that I'll be presenting today and who provide funding to my research in general. And I also do just want to point out that I'm going to be talking about an adapted semi-structured interview today, the ATIS with the Autism Spectrum Addendum. That is published by Oxford this year, and I get a portion of the royalties for that. So you should know that and take everything I say with a grain of salt. But I will say that all of the research I'm going to be presenting today was published and collected before I got any royalties for it. So, and I also do want to acknowledge the land which I'm privileged to conduct my work on is the traditional and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. And I also want to acknowledge that I'm presenting here today, I believe, on the Haudenosaunee and Anishinaabe nations land. And I just want to acknowledge my humility and respect for being able to present from this place. Okay, so the majority of this talk is going to focus on the expression of anxiety disorders and how we differentiate anxiety disorders from normative anxiety in autistic youth. But before we get into that data, I just want to take a moment to talk with you about the challenges associated with anxiety for autistic individuals and why recognizing and addressing those challenges is such an important goal. So why do we care about this? And as I do this, I thought it would be good to kind of begin with the words of autistic individuals, their caregivers and providers to illustrate those challenges. And in general, the talk is going to pull quotes from actually qualitative research, that studies that highlight the perspectives and accounts of autistic individuals and those that support them to illustrate some of these key findings that we see actually in the broader quantitative literature. And this is just coming from, I'm a clinical psychologist, integration of practice and research. That's what this talk is going to try and do too. A lot of what the research is about has been inspired by the clients that I've had the privilege to work with. And it's also those personal accounts that really ground the research that we do. Sometimes anxiety can build up on itself like a brick on an accelerator pedal. Whenever you make a mistake due to anxiety, you become more anxious. It's just something that keeps being in your head and you can't get it out and you can't focus on other things. Anxiety disorder is different from anxiety, which is an emotion we all experience and which typically serves an adaptive function. Anxiety helps us stay safe, plan for the future, get things done. Anxiety disorders occur when that typically adaptive, informative emotional system, instead of helping us navigate our lives, it shuts us down, becomes all-encompassing. Anxiety disorders kind of dominate and deplete our attention as opposed to adaptively directing it. Research suggests that anxiety disorders are associated with specific additional difficulties for autistic individuals, things like increased depression and self-injurious behavior, reduced quality of life, more sleep problems, more gastrointestinal illness, a reduced willingness to initiate social interactions, and increased family stress. He shuts himself down and he goes to bed. He'll be in that room for 15 hours. So children can become so overwhelmed and depleted by their anxiety that they withdraw from the world for extended periods. A mother whose son has a severe dog phobia describes, "I'm risk assessing where it's appropriate to go and what is safe. I'm a single parent, so I have to really think, where can we go? Where can we manage? And what's safe? And as part of that risk assessment, I think, will there be any dogs? So every time I go out, I consider the difficulties that may arise to minimize the anxiety. Every trip out the door requires an accounting of risks, feasibility, safety." Anxiety disorders can make it hard not only for autistic children, but also their families to navigate the world around them and to complete daily tasks. And this brings us to the tricky question and the different meanings sometimes attributed to the word accommodation. So accommodations for many autistic children and their parents, particularly if you're thinking from an educational framework, represent kind of important changes to a child's learning environment to actually allow them to access the same content as their peers, to give them an equal footing by reducing barriers, or thinking flexibly in order to promote their inclusion, their independence, and their growth. That's one way that we can think about the word accommodation. But in the context of anxiety disorders, accommodation actually has a much trickier meaning. So in anxiety, we see caregivers changing their own behavior to help a child reduce or actually avoid the anxiety. And accommodating anxiety in this way is associated with actually more severe anxiety, a more severe impact of that anxiety on the child's life, more behavioral outbursts, and a poor response to anxiety treatment. The thinking is that the accommodation is both a reflection of the intensity of the anxiety, right? So it's not surprising that at some point parents would simply say, "We're not doing this. This is too overwhelming to my child," right? However, there's also a thought that that avoidance serves to maintain the anxiety. More and more becomes avoided rather than mastered, and the child and family's life become increasingly restricted. So while some accommodations can empower a child, others, particularly accommodations for anxiety, may have actually the opposite effect. And figuring out which is not always easy. As an illustration of this, a study by Adams and Emerson in 2020 found that with autistic children, difficulties tolerating uncertainty were particularly associated with family accommodation. And I think this example really highlights a critical conundrum. When an autistic child is struggling to navigate changes in their routine, when you see that insistence on sameness, do we try and keep things as predictable as possible for them, knowing that's a feature of autism? Or in doing so, are we actually feeding their anxiety? Okay, so it shows you the intersection of autism and anxiety and where that can get tricky and have really complicated treatment implications. Okay. And there are also subtler but very important costs to anxiety. So there's the parable of the little engine that willed itself over a tall hillside carrying a very large train by saying, I think I can, I think I can, I think I can, I think I can. Okay. What makes anxiety disorders particularly dangerous and debilitating is that when you have an anxiety disorder, you look at a challenge and you think, I can't. You not only have to deal with the hill, you have to deal with the doubt. There are many challenges in life. That may be particularly true for some autistic children. Yet there is a distinction between the challenge itself and the psychological distress and suffering that often accompanies and exacerbates it. Reducing anxiety is a way to remove that additional layer of difficulty and thus to make a huge difference in the lives of people on the spectrum. We may not always be able to take away the challenges, but we can work on building resilience rather than suffering in the face of them. Okay, so this is where I think anxiety is very important. And also anxiety disorders are potentially a problem with promise. So across clinical trials, of which there are now over a dozen, we see that 58 to 71% of autistic youth, and these are youth without intellectual disability, will experience a remission of their primary anxiety disorder following a course of cognitive behavioral therapy. Both group and individual programs have been supported, and this research base is now growing and focusing on expanding access. So emerging work supports the efficacy of behavioral and modified CBT approaches to treat anxiety in autistic youth with co-occurring intellectual disability. There are now also school-based and step care programs that are really aiming to get these interventions to people expediently and cost-effectively. This is a slide illustrating the main outcomes from the treatment of anxiety in autism spectrum disorder, or TASE study. It was a rigorous comparison of standard CBT, which is called Coping Cat here, relative to a modular autism-tailored CBT called the BIACA program, and treatment as usual in the community. And what they found is that both standard and adapted CBT outperformed treatment as usual. So they both worked. But there were also particular benefits associated with BIACA, with the adapted program, the autism-tailored program, including greater anxiety improvement, greater reductions overall in internalizing symptoms, and also broader social difficulties. So what I think are the important points to take away here is that there is evidence to suggest that standard CBT programs can be of help. This may be important from a dissemination and access standpoint. Many more clinicians in the community are familiar with standard CBT protocols and adapted CBT protocols for autism. However, it's also clear from this work that there are additional advantages associated with autism adapted programs. So there are benefits for considering and tackling in the ways in which autism and anxiety often intersect. And I think these results may also hint at kind of the amped up complexity of anxiety within the context of autism, which is what's going to be a focus of the talk. And hopefully I've got you by now. But if not, I have more. So in addition, anxiety is an important issue for us to get a handle on, because being able to accurately detect and measure anxiety may also be crucial to kind of reduce variability in the constructs of interest to autism research, and just generally to understanding and supporting autistic individuals. So we know that a lot of the variables we often look at to better understand the strengths and challenges and underlying mechanisms of autism itself can also be influenced by the presence of anxiety disorders. For example, anxiety disorders in individuals on and off the spectrum are associated with increased repetitive behaviors, sensory sensitivities, differences in social motivation, differences in social approach and skill, cognitive testing performance, and differences in the size and function of various brain regions often studied within the context of autism. So our ability to accurately measure the presence of anxiety disorders in autistic individuals may really lend insight into the notable variability we observe in studies on all these constructs to date. I'll also note that research focused on co-occurring mental health conditions within autism and focused on well-being are really shared top priorities for a broad array of those in the autistic community, including autistic individuals, clinicians, parents. So this is a shared priority for many people. Okay, hopefully I've got you now. We're on the same page. This is important. Okay. In many ways, this first half of the talk is really just prelude for another goal, which is for me to convince you that to address these challenges of anxiety and autism for us to be most effective, we must begin by better recognizing and understanding the diverse ways that anxiety is experienced and expressed by autistic kids. How we define and assess anxiety disorders in autistic individuals, how we draw the lines about what to conceptualize as autism versus anxiety has real implications for estimating the size and characteristics of this public health risk, and for identifying who's in need and likely to benefit from available treatments and what treatments we should be giving them. Yet the process of drawing those boundaries is often not so simple. A mother describes, sometimes it's very difficult to understand whether it's an autistic behavior or whether it's behavior caused by anxiety or both. My hunch is that most expert clinicians would tell you the exact same thing. There are several reasons why drawing the lines or making these distinctions is so challenging. So one reason goes back to how we differentiate adaptive anxiety from anxiety disorder. Part of how we do this is by evaluating how realistic or protective an individual's fears are. And what we see in autism is many reasons why having more fears might actually make a whole lot of sense. So Richard, an autistic adult, discusses his social anxiety. He worries, does that person like me? This is a quintessential social anxiety fear, right? Will I be liked? But Richard also recounts, others were not interested in me. The other children ignored me. So many times people on the spectrum are worried about social encounters because they should be worried, because they are actively being bullied or more subtly, politely, but still painfully excluded. And in such cases, those worries may actually be protective. I think the quote illustrates how important it is to think carefully about how realistic and adaptive a worry is before pathologizing it, and why this can get complicated quickly when autism is also in play. Other key reasons why differentiating anxiety disorders and autism can be challenging are the overlap of autism and anxiety symptoms and the distinct ways that autistic individuals may experience and express anxiety. So this is a description of Donald, written by his father and printed as part of Leo Kanner's original characterization of autism in 1943. So this is an old quote, but it's an interesting one. By the way, not everything in this 1943 article is perfect, and I'm not endorsing the whole article, but I'm saying this is a useful quote. So this summer, this 1937, we brought him to a playground slide. When other children were sliding on it, he would not get about it. He seemed horror-struck. The next morning, when nobody was present, however, he walked out, climbed the ladder, and slid down. And he slid on it frequently since, but slides only when no other child is present to join him. So Donald's father uses the word horror-struck. It's horror-struck. But what exactly is Donald afraid of? Perhaps he's afraid that the other kids will tease and dislike him. Alternatively, perhaps Donald is not particularly attuned to or concerned with his peers' judgments, but he does fear how unpredictable they are. Perhaps his worries arise from his struggles to know what they want or what they're going to do. Maybe he's not scared at all. He's just as stressed because they're getting in his way. So I think the quote illustrates how social avoidance like Donald's might reflect a feature of autism, a symptom of anxiety, or some combination of the two. some more recent illustrations, not from the 40s. Audrey, an autistic adult, describes, I get anxious in social situations as I don't see emotions in people until they get to a 10, and then it's an explosion, and I don't know when it's going to happen. A parking lot can be terrifying because of all the headlights. A mother describes her son's anxiety around changes in routine. At the beginning of the term, they dropped the first period of the first day. M, this is her son, couldn't sleep that weekend. He has to bring the books in for that period, even though he doesn't have it. So I think in all of these examples, we see key features of autism highlighted, right? Social communication difficulties, sensory sensitivities, a desire for sameness. But we also see examples of anxiety layered on top. So it's not just that M is refusing to accept a change in his routine. It's that he was worrying all weekend, unable to sleep because he knows that it's coming. That's the anxiety. So a growing body of research is exploring this possibility that anxiety may come in many different varieties in autism, both similar and distinct from the anxieties expressed by non-autistic or allistic youth. And it's our working hypothesis that distinct expressions may reflect anxiety influenced by the different ways autistic individuals perceive and experience the world. It's the hypothesis. Similar presentations are anxiety disorders that are easily fitting into the kind of these traditional diagnostic manual prescribed criteria, and that are looking similar in autistic and non-autistic youth. Whereas these distinct expressions are those that are really harder to categorize, those which feel problematic to shove into those categories because they don't really fit there, but also problematic to simply attribute to autism for fear that we might actually be missing an anxiety or fear, that we might be discounting those things. Okay, so this review is a bit dated, published over a decade ago at this point, but I'm including it because I think it really reflects where the work began. And it was conducted 2012 at a time when interest in anxiety and autism was really starting to ramp up. So we were seeing a real proliferation of studies, but also a lot of inconsistency in the results, okay? So when you looked across studies at that time, and I'm pretty sure this range still stands because it's going to be hard to beat, but when you looked across all of these studies that had been done on anxiety and autism, the prevalence ranges were anywhere from 11 to 84%, okay? Now, this is not great because it's pretty similar to saying 0 to 100, okay? So a lot of inconsistency. If you focus more on epidemiological studies using semi-structured interviews, you're going to get something closer to 40 to 50%, but there was still a good amount of variability. There were also a lot of inconsistencies coming out about what are kind of the associated characteristics of anxiety for kids on the spectrum. So some studies would suggest higher IQ is associated with more anxiety, and yet a seminal review at the time found the exact opposite, that actually lower IQ would be associated with more anxiety disorders. There were inconsistencies in terms of is anxiety associated with more or less autistic traits, a child's verbal ability, their social interest, okay? For some part, inconsistencies are likely due to differences in the methodologies of the studies. However, we hypothesized at the time that inconsistencies may also be due in part kind of differences in symptom presentation and measurement, okay? Differential diagnosis is a challenge, as I've hopefully planted the seed, okay? There's overlap in what we consider anxiety and autism symptoms. Anxiety disorders are really dependent on developmental context, right? So what is a normative anxious response in a young child could actually amount to an anxiety disorder in a much older child. We have to think about the developmental context. For kids on the spectrum, we know that their development is often delayed and also can be sometimes all over the place, which complicates how we think about their anxiety. We also know that there are these differences in the way that anxiety might be expressed. And with all that as background, the research for many, many years was really relying on measures that were not designed for autistic youth. So it was relying on measures designed for a non-autistic population, just applied to this one. So they weren't really designed to try and parse these things out, and we didn't have a good sense of their reliability or validity in this population. And in general, even across the studies where we're using semi-structured interviews and clinical interviews to try and get the anxiety, you didn't really see a systematic approach to kind of the diagnostic complexity or these distinct expressions of anxiety that I've mentioned. There was this really outstanding question: how do we define or operationalize what anxiety disorder is within the autistic population? This picture is called My Wife and My Mother-in-Law. Okay, so you're either going to see a youthful woman, it's the side of her face, and she's got like a boa thing going on and a choker, okay? Or you're going to see potentially an older woman with a large nose, and the choker's instead her mouth. Oh, wow. Okay, yes. So I include this picture. Hopefully you can see it both ways. Just to remind us that we could be looking at the same thing, the exact same thing, and yet nonetheless see something quite different depending on our vantage point and our perspective at the time. Okay. This is relevant because even when you looked at in this review, and this was just descriptive, this is just observational, so we're not running a meta-analysis here, but this is just looking across these studies where they had done clinical interviewing and reported on the rates of things like social anxiety disorder, generalized anxiety disorder, and OCD in the autistic population. Again, you see a fair amount of range in the rates of anxiety, these anxiety disorders being reported. And one thing that we observed at the time is that you would see much lower ranges when they are more stringent about applying the diagnostic criteria. So Leifer et al., for example, required, you can't see it because it's cut off, but they required a fear of negative evaluation in order to diagnose social anxiety disorder. They would not diagnose it if that really wasn't confirmed by the parent. And you see the lowest rates in that study. They also tried to differentiate generalized anxiety disorder from just an agitated temperament, and as a result, diagnosed a lot less GAD in that study. Okay, so trying to differentiate GAD from just potentially emotional dysregulation in a young child on the spectrum. Muris et al. In 1998 only diagnosed OCD in about 11% of their sample, where the parents felt certain that the ritualistic behavior was accompanied by negative affect or distress. And that was quite a different number from actually the percent of ritualistic behaviors seen in the sample overall, which is 73%. So you can see the difference here again, right? How strict you're going to be could really influence if you're saying, oh, there's 73% of ritualistic OCD behavior in this sample versus 11. So fast forward a decade. This is the final product, okay, which is that we tried to come up with a systematic approach, an adapted interview to really guide folks in sorting through some of this diagnostic complexity to the best that we can. I'm not going to say it's always perfect, but we're trying to be a lot more careful. Providing a semi-structured interview to do this, that's really designed for assessing anxiety disorders in autistic kids. And the thing that it does is it provides specific guidelines and additional prompts or information to differentiate overlapping autism and anxiety symptoms. So to help the clinician and the parent, usually, sort through, is the social avoidance due to, I'm scared what people think, I'm scared what they might want to do. I'm not really thinking about what they think at all. That's not actually on my radar yet, but I'm scared in the social situation still. Or no, I just don't want to. Okay, trying to help clinicians and parents sort through those things. Querying for these distinct expressions of anxiety. So those fears of change, anxiety about projectors, okay, the color purple, gloves, the happy birthday song, okay, including those. And when we're doing the interview for kids who have very limited language ability or co-occurring intellectual disability, really guiding the clinicians and the parents to try and focus on behavioral examples to do our best to figure out what the function of distress behavior is and if it's actually really supporting an anxiety response or not necessarily. Okay. And across multiple studies, we see good inter-rater reliability and retest reliability. And this is through preschoolers, through teens, including the data is less robust, but we have a couple of good preliminary studies now suggesting that we can achieve good reliability also with kids who have co-occurring intellectual disability and limited language. That's just a parent interview in those cases. We also see evidence for discriminant and convergent validity. And a simple way of kind of understanding what that means is that this interview is going to converge with other measures of anxiety, but hopefully provide an even more sensitive capture of the anxiety in kids on the spectrum. But it's also not triggered by, for example, just the child having more autistic traits or more attention problems or more aggression. So you see real divergence in, for example, measures of attention and aggression from this measure of anxiety. So it's not just escalated by disruptive behavior or distress behavior in general. We can do a more specific read on the anxiety. Okay. Okay. And now I'm going to do a little clinical interlude just to give you a little peek under the hood of what this interview does and how we're approaching it. Not going to do a full training, but a little peek. Okay. So the main anxieties that we focus on are separation anxiety, social, generalized, specific phobia, and then we are assessing for OCD as well. Panic and agoraphobia are anxiety disorders in the DSM, but they are much less frequently endorsed in particularly young children, including kids on the spectrum. So they haven't been as big a focus of the research. And PTSD is a whole other research interest of mine, so that's another talk. Again, remember that determining these anxiety disorders, we're really trying to differentiate when anxiety is adaptive versus maladaptive, okay? And thinking about the context of the child and what they're experiencing related to their autism in order to make those decisions. So, social anxiety disorder. The kind of hallmark symptoms of social anxiety disorder, if we're going by the DSM, so the diagnostic manuals, are an excessive fear of social ridicule and rejection, social avoidance and social difficulties. And social anxiety can be specific. It could be performance anxiety. So I just freak out when I have to get up here and talk in front of you all. Or it can be more generalized, right? Which is I'm afraid to let people really get to know me because I'm scared about what you're going to think about me in a variety of different settings. So considerations within the context of autism. The adapted interview asks specifically about some of the things on the screen here. So number one, base level of social motivation. Okay. This is important because in order for us to assess what the social anxiety disorder is actually contributing or detracting from a child's social functioning, we kind of need to have a sense of like how interested were they in being socially engaged in the first place. Okay. So before we say, oh, this anxiety is keeping Jimmy from doing A, B, and C, D things, social things, we have to have some sense that that was actually something he really wanted to do, right? In order to attribute to the anxiety. And that's important to parse out because we know that social situations can be difficult, unattractive, or unappealing for a variety of reasons for kids on the spectrum. Okay, so we want to know where the social motivation is. Also looking at the timeline. So the trajectory of social motivation can sometimes be really useful. Thinking about this differential again as well. So if we have a kid who actually was really tuned out and not particularly interested in social interaction and then has become more interested over time and at the same time worried, that's a better nod in the direction of social anxiety, I think, than a kid who's never been interested. Similarly, if we have a kid who was quite interested, had some bad experiences, and now they are starting to withdraw and they're worrying about negative feedback, that's more consistent with social anxiety. Okay. Along those lines, we specifically ask about the child's bullying and peer rejection history, because you want to know that before you determine if their anxiety is excessive, adaptive, or maladaptive, right? You kind of need to know what they're experiencing. And it can be easy to think, well, oh, most kids on the spectrum are going to have some negative social experiences. So would that explain all social anxiety? You have to be a bit more nuanced than that. So there will be plenty of kids who could have had a negative social interaction. What we're looking for in social anxiety is when actually that negative experience now becomes overgeneralized. It balloons. It goes beyond just a certain set of people to all people. It's the kind of thing that keeps the kid from even being able to participate in a supportive social group because they can't get through the door, right? Because they can't imagine at this point that anybody could be supportive. So that's when it starts turning towards anxiety disorder. We think about their social awareness. So in order to give a DSM consistent classic expression of social anxiety disorder, or that diagnosis, there should be some awareness about what other people think and a worry about what they think, or that they're not going to like me, or I'm going to be embarrassed. These are kind of central features of social anxiety disorder. There are some kids on the spectrum who are worried about this and they just can't articulate it. There are other kids who that's just not really on their radar yet, right? That's not something that they're particularly tuned into or worried about, okay? In those cases, we might be thinking more, is the social avoidance just, I'm not particularly interested socially? That goes back to the social motivation. Or are they scared of the social situation for different reasons, okay? And that we would actually put in a different category than social anxiety disorder in this interview. That's one of those distinct expressions that we want to capture in autism. And finally, you want to have a sense of what their social opportunity is. So how frequently do they actually have opportunities to connect and have positive experiences with other kids? Just again, to better understand the context of what's their social environment, what are the social experiences they've had, and what ways is anxiety really adding to the situation. Now, for those kids who we don't really see a fear of negative evaluation, but they do seem to be very fearful in social situations. They're worried about what to expect in social situations. We have a category called this other social fear. So this is a place for you to capture that distinct kind of expression of social anxiety in kids on the spectrum without jamming them into social anxiety disorder broadly, where they don't perfectly fit, right? Where they don't have quite the same profile, but without just attributing to autism and then missing the fact that anxiety might be part of the picture as well. Our understanding of this actually came, the first time I ever heard about this fear came from a teenager who was in one of our first studies, who had an IQ of like 158 and was able to really clearly articulate to me, like, I'm not worried about what other people think. I just don't know what they're going to do. It makes me really anxious. That whole situation is like really overwhelming for me because I have difficulty. It's like you're interacting and you know 50% less than many other people in the scenario, and that makes the situation anxiety provoking. So that's where our understanding of these kind of other social fears came from. And you can also see it reported by caregivers and autistic adults in these qualitative studies. And it's important to differentiate this also from sensory concerns and concerns related to change, which is also something we see in kids on the spectrum, which can be another reason why kids would be afraid of a social environment that has nothing to do with social, actually. Okay, so for these other social fears, we're really looking at the kids who are quite anxious because they're trouble kind of knowing how to navigate a social situation, not just because people are loud. We put that someplace else. Or because they're quite rigid, or they really want things in a particular way, and you can't control other people very well, and they're not going to follow the routine. Okay, again, we put those someplace else. So it's like really getting into the weeds, but I do think it's useful. When assessing specific phobias, so these are things like probably many people in this room have subclinical specific phobias. Some of you might have clinical ones. I am right on the edge in terms of my fear of rats and heights. I would put them subclinical at this moment because they don't actually interfere in my life in any way. But when I was growing up in New York City, it was more of an issue. Like, I was not really into taking the subway. And And there are certain like rat blocks that I would avoid. And it would sometimes take me a little longer to get places. I still think it would be subclinical because I didn't have like major interference in my social work or school life. But I was avoiding some things. Okay, so those are the specific phobias: fears of vomit, fears of heights, all of those things. A big one for kids, that's a very common fear, is the fear of loud sounds. This is one we see for kids on the spectrum a lot, okay? But it's also one that really, I think, highlights for you, or for me, I think it's important to think about the difference between having a sensory sensitivity to loud sounds, and when you hear a loud sound, being very upset and needing to get away from that, from an actual phobia of loud sounds, okay? The anxiety disorder that can, for some children, be layered on top of that. So you might be asking, how do we differentiate that? I will tell you how we try, okay? So in these interviews, the way we're kind of conceptualizing what the anxiety disorder is, are the kids who, for example, will not go to school because they're afraid there might be a fire alarm. The kids who are going to the nurse's office or checking with their teacher multiple times a day, looking for reassurance that there will not be a fire alarm. Okay. The kids who, whenever you go to a new place, are casing the joint to find where the fire alarms are. And they and their family cannot do anything else until they've located where those fire alarms are, they know what they are, okay? That is the anxiety. That's the anxiety disorder, because it's actually the fear of being exposed to those sounds before they've even happened that's actually causing significant interference in the child's life. It's the anxiety that's driving the impairment in functioning, okay? And that's different from when the loud sound goes off. It's hugely painful for me and I have to get out of this scenario, okay? I bet they go hand in hand, okay? But there will be some kids who you really just see the sensory sensitivity and not necessarily the phobia layered on top, and other kids where the phobia is actually a really, really big problem. And it's creating this huge restriction in their mobility, right? Because they're so worried about exposure. In addition to those things, for kids on the spectrum, we often see what have been coined kind of unusual fears, or I would call them autism-related or idiosyncratic fears. These can be things like graffiti, water draining, specific songs like Happy Birthday. Happy Birthday is a big one for a lot of kids. I had a client who was very afraid of the song Soul Sister by Train, which is a little dated now, but terrified of that song. Microwave beep, gloves, cardboard figures, black toilet seats, men with beards. Again, there are examples of this in Connor's 1843 article. There are examples of this kind of consistently throughout the literature. They're often thought of as kind of like a feature of autism. And yet it's also quite clear that the kids seem very afraid and anxious and scared of these things, but they're not kind of common phobias that you see in kids not on the spectrum. Very unusual phobias are not restricted to autism. So you will see in some of our studies, we've seen kids who were afraid of buttons, for example, who weren't on the spectrum. And people will have kind of fearful or disgust reactions to all kinds of things. Sometimes like holes, sometimes really freak people out. Okay, so yeah, there you go. There's a specific name to it. So it's not unique to this population, but we do see a lot of it in this population. And in our interviews, we're trying to capture those things. And we're trying to measure them, okay? As opposed to just saying, oh, it's like all the other phobias, or it's just a part of autism, and then we're not capturing the anxiety piece. Another example, generalized anxiety disorder. So GAD, this is often the kids who have a worry du jour, or whack-a-mole. You deal with one worry, and then there's going to be another one kind of coming up. They worry about their performance. They worry about getting sick. They worry about world events, school, crime. It may result in a lack of willingness to try new things because they're worried about doing them well or being good enough. Intolerance of uncertainty is something that's talked about a lot within the context of generalized anxiety. And if you're working in the autism world, you might say, well, how is that different from insistence on sameness, right? So this wanting things to be a certain way or being concerned about not knowing what to expect. And GAD is often associated with sleep disturbances and somatic symptoms. So stomach aches, headaches, muscle aches, things like that. For kids on the spectrum, some of the things that can really come in play here that we want to sort through and think carefully about are the differences between kind of just perseverative thinking and worry. Okay. again, this might be one where if you have perseverative thinking, maybe you're at risk for developing worry, but they're not always exactly the same thing, okay? But we want to identify and think about those kids who just tend to get stuck in general on worries, but also many, many other things. Because if you're not aware of that kind of tendency, you could potentially really over-pathologize them. Because when you ask them about things they're afraid of, they're getting very stuck and telling you they're afraid of everything. But if you did an interview with them about, different muffin brands, you would also talk for an excessive period of time about muffins, right? So we need to be just a little careful of that. We also want to differentiate again between reasonable and excessive worry, particularly when we're thinking about worries about performance in school or being good enough. If the child is actually experiencing learning difficulties, challenges at school, etc., we want to keep that in mind before we pathologize those worries. The other things that come up when you're assessing for GAD that are kind of more of these autism-related or autism-related kind of presentations, distinct presentations, are we do see some kids who develop a lot of anxiety around their focused interests. It's not all kids who have focused interests because the rates of this special interest sphere, is what we call it, are actually quite low, which means the clinicians I have trained are doing a good job, okay? So it's not just getting upset when you're kept from something you're quite interested in. What we see for some children actually is excessive worry about, are they going to have access to it? Is someone going to mess with it when I'm not there? Is somebody going to move it around? I need to fix it. I need to count it. And again, that worry actually starts to interfere with their day. There's one kid who comes to mind who would set an alarm for 5 a.m. because he was worried about losing time with his special interests at the end of the day. And that worry began very, very early for him. So he wanted to get up super early to make sure that he wouldn't lose time for that, okay? And that preoccupation or that worry about the thing was really, really getting in the way. So that's where we think about kind of a special interest or focused interest sphere. What we also see that can be confusing and difficult to disentangle from generalized anxiety, sometimes it's part of generalized anxiety, are these fears of change. So that extreme anxiety about changes in the schedule or novelty. For many kids on the spectrum, you'll see that within the context of generalized anxiety. That's not that atypical. It's often a part of generalized anxiety. But then for some kids on the spectrum, we don't see generalized anxiety at all. We see actually quite focused anxiety around changes. Okay. And this is a way, again, to kind of capture that anxiety without just losing it, saying, oh, it's just autism, or putting it in the GAD category when it doesn't quite fit there. We also differentiate those fears or that anticipatory anxiety about change from just melting down when a change happens. Because those negative reactions to change, so just when change occurs and they're having trouble cope with it, not clear to me that that is actually consistent with an anxiety process, okay? So we try and pull these things apart. Okay, last slide, and then we'll be done with our clinical interlude. And we'll go to the data and then we'll finish up. OCD. OCD is like really probably the toughest one because it's so hard to get at unless you can actually get inside a kid's head and they can articulate for you what's going on. And sometimes it's very hard, if not impossible, to do that. However, some of the things we can think about, and we try and think about this interview to differentiate true OCD behaviors from just ritualistic or repetitive behavior or self-soothing behavior that you might see for a kid on the spectrum, is this focus on negative affect. And not just negative affect when you interrupt the behavior. If a kid is super happy and actually has positive affect when they are engaging in their ritual and repetitive behavior, but then very upset when you stop it, I would not put that in an OCD category at all. If, however, they are extremely distressed until they complete a ritual, extremely distressed if you were to prevent them from doing the ritual, and then have some brief relief, but then get distressed again and need to do the ritual again, that is more consistent with an OCD profile. That negative affect really driving the need to complete the ritual or the compulsive behavior. This is a credit to Marty Franklin, who is a big pediatric OCD researcher for many years at Penn while I was studying there. And what Marty always told me is look for evidence of a return serve. So part of how we think about how OCD works is that there's a very distressed feeling or often a distressing obsession, image, or thought that comes into the child's mind, and something needs to be done to bat it away. And it's usually a very specific thing. It has a specific order. It has to be done in a specific way. It needs to be done in a certain number of times, okay? Because it's the return serve. It's getting that out of here. That is different than just doing something over and over and over and over again to calm yourself down, okay? There's a precise relationship that you want to look for, if you can. And that's also helpful for thinking about kind of ritualistic versus repetitive behavior. Is there an order? Is there a number? Are there rules? Is there precision to it? Okay. The differentials here are restricted interests, repetitive sensory seeking behaviors, and also just rigidity. So just wanting things the same way also can sometimes look compulsive. So we try and use these to kind of guide, again, the interview process. Think about really only diagnosing OCD when there's good evidence for it. And then we do have a category called ambiguous compulsions for those things that look really compulsive. The child is really negative, but there's also, it's not as clear a picture of OCD. So we have a place to capture them. Okay, that's the clinical interlude, just to give you a little sense of what it's like to do some of these interviews, the things that we're trying to do. Okay, and now, can we increase precision and nuance? And what might we gain by doing so? Okay, so across several research studies, we'd endeavor to carefully characterize anxiety disorders in autistic youth using this adaptive clinical interviewing approach, kind of reliably differentiate between autism and anxiety-related behaviors and capture those distinct expressions of anxiety. So these are two studies that were conducted 6 years apart. One was conducted in the Children's Hospital of Philadelphia and the other at the UC Davis Mind Institute. These were both samples that were recruited just for imaging studies of autism, so they were not recruited for anxiety, okay? The 2014 study, the kids have an IQ range of 67 to 158. And in the Mind Institute study in 2020, we actually have a full range, so below 40 to, I think, 160 something. So kids with and without intellectual disability in this study. What you can see in both of these studies is that 30 to 40% of autistic kids don't meet criteria for any anxiety disorders when we take this approach. That's the white slice here. This is important, and this is where I always start, because sometimes it can be easy to think that all kids on the spectrum have anxiety disorders, and they don't. It's not the case. Okay. About 50% of autistic youth have traditional anxiety disorders. So these are the dark slices here. Okay, so these are things that meet the DSM criteria, full criteria. Okay. These are the anxiety disorders that are similar to those seen in non-autistic youth and consistent with the DSM. 50% or more of kids with those traditional anxiety, this is this slice here, are also going to have these distinctive fears that I've been talking about. So for about a third of autistic kids, traditional and distinct anxieties kind of coexist. And finally, maybe the most interesting slice, this is light blue one, 15 to 17% of autistic youth across these studies had only a distinct anxiety presentation, okay? And the reason that's meaningful, I think, is that depending on how you want to characterize those distinct expressions as autism or anxiety, it really could change your estimate of the rate of anxiety disorders in this sample by up to 17%. We also saw in this study that they had some shared and some distinct predictors. So we know traditional and distinct anxiety are significantly related. They were both also related to having an anxious cognitive style. Only traditional anxiety was associated with stronger language ability and sensory sensitivity. Distinct anxiety was associated with having more autistic traits. So distinct anxiety is predicted by the convergence of anxiety and autism, might be one way to think about this. What's also interesting about language ability, and we also controlled for IQ in this study, IQ was not significant once you have language ability in there. But it's important to know that language ability was not associated with distinct anxiety. And one way to think about that is that you're going to see these distinct expressions of anxiety in the kids with 158 IQ as well as with 50, okay? And it's also potentially telling us that distinct anxiety is not just anxiety in kids who don't have the language ability or the cognition to articulate GAD, for example. I'm running a little short on time, so I'm going to skip through some things. In the 2020 study, so this is the study with kids with and without intellectual disability, carefully characterizing the presentation of anxiety really showed us or shed some light on how intellectual ability might relate to anxiety in autism. So we found similar rates of children with and without intellectual impairments presenting with both impairing traditional and distinct anxieties. So ID didn't really change your likelihood of having an anxiety disorder. However, when you looked at the types of anxiety disorders being reported across groups, differences emerged. So specifically, the anxiety of children with intellectual impairments was primarily comprised of specific phobias, things like fears of dogs, dentists, heights, loud sounds, and of distinct anxieties. It's meaningful because I think it suggests that cognitive abilities are related to the expression of a child's anxiety disorder more so than the likelihood that they're going to have one. Okay. It also offers some insight to why studies suggest that brief anxiety measures, so those that developed and normed for non-autistic samples, have really diminished accuracy in autistic youth, particularly when they have co-occurring intellectual disability. So the traditional anxiety presentations that those measures screen for really reflect just one part of the picture for autistic youth. And it's a very small part of the picture for autistic youth with intellectual disability rather than the complete picture. So when you're having a measure that's only asking about generalized anxiety symptoms, like, of course, it's not going to capture the anxiety of some of these kids. We applied the same diagnostic approach to better understand the anxiety presentations of autistic kids who completed kind of intake appointments in that randomized clinical trial I mentioned, the TASE trial. And what we learned was that the vast majority of those kids met criteria for a traditional anxiety disorder, for classic DSM stuff. And only 2%, this is the light blue slides, had just a distinct presentation. Still, however, of those kids who had the traditional anxiety, 50% of them still have these distinct presentations, okay? So I think this means is that distinct anxieties may be very common in autistic kids who are receiving cognitive behavioral therapy, even if they weren't the fears that got them into treatment, okay? It also suggests that children with only distinct presentations may be less frequently recognized as experiencing anxiety and requiring anxiety treatment. And whether this holds true in community treatment settings requires further study. This was part of an RCT. But I think the initial findings provide some strong rationale for better understanding these fears, their role in autistic kids' clinical presentation, and their expected treatment response. Okay. I think I'm at an hour, so I'm going to skip through these next ones, but we've also studied this in preschool children. You can see they have less anxiety overall, so only about 40% of the sample. It's actually only around 30% if you're just capturing the traditional anxiety presentations. Again, 13% are just going to have that distinct presentation of anxiety. And this is really interesting, but very preliminary. It's just a first study. It hasn't been replicated yet. But what it's showing us, it's from this autism phenome study from UC Davis Mind Institute, is that the kids who actually have traditional versus distinct anxiety have very different patterns in terms of amygdala function and growth over time, okay? So the top line is actually kids who have just traditional anxiety. They had larger amygdalas with a faster growth rate versus kids with just distinct anxiety presentations on the bottom with purple, you see actually the opposite effect. Not entirely sure what this means yet. And it's a sample of 71. And these group sizes get pretty small when you start breaking them into who's got distinct anxiety and just traditional, who's got the combination, which by the way is in the middle. So we have to be really careful. I'm not going to get over the skis on this one, but I think it is interesting. It's always interesting to me when we think about a clinical phenotype and it's actually connected to something under the hood, under the surface, potentially. Okay. Limitations and future directions. I just want to note that these samples up to this point have mostly been white and male. And also a lot of this data is based on just a parent interview as opposed to parent and youth, even though when we have kids who are able to articulate, probably a combined approach is the best practice. And future directions, really interested in thinking about mechanisms. So where are these distinct anxieties coming from? Particularly if they're the confluence of autism and anxiety, what does that mean in terms of why these anxieties are looking this way? And then also how we're going to treat them. And this is where we come back to that question of accommodation, of how well our exposure is going to work. If it's a sensory sensitivity or it's a sensory driven fear, do we need to be really thoughtful about proceeding with exposure in that case, even if anxiety is also implicated? Okay, last slide. Connor in 1943 again wrote of Alfred in his original case series. He had a good deal of worrying. He frets when the bread is put in the oven to be made into toast. He's afraid it will get burned and be hurt. He's upset when the sun sets. He's upset because the moon does not always appear in the sky at night. To address the challenge of anxiety and autism, I think we must begin by better recognizing and understanding these distinct expressions of anxiety. So thus far, our research is suggesting that they're prevalent. They're impairing for autistic kids. They're also likely under-recognized and under-treated in this population, and they're adding considerable variability or noise to the research that's actually seeking to characterize not only anxiety and autism, but autism itself. And many thanks to the children, families, clinicians, collaborators, and funding agencies who've made all this work possible. Thank you so much.
Thanks for your wonderful talk. I was wondering if we wanted to, maybe we could start with any audience questions. If anyone has any questions they want to start off with, go ahead.
The one we skipped over, I'm very curious about why you think that there's a lower prevalence of anxiety in preschool or younger children.
I think that's a good sign. That's pretty consistent.
That's fine with that.
Well, so that would be pretty consistent with what we know about anxiety in the general population of kids in general as well. So just developmentally, you tend to see more specific phobias and separation early on, and then things like social anxiety and generalized anxiety are going to come in more in kind of the adolescent period, and then panic and agoraphobia towards the end of adolescence. So just in general, we usually are not diagnosing as many disorders in young children as not, and this would be following that pattern. And why that is, probably because you become more aware over time. There's more to be worried about. There's less structure from your parents. You know, there's a lot of scaffolding and protecting that kids have early on that's supportive. And then the challenges of life come over time, and that's where you can sometimes see the anxiety is helpful, but then it starts to be not helpful. And I'll also note that about 15% of kids, even though they weren't meeting full criteria for anxiety disorder, they were what we'd call subclinical. So we kind of flagged them as probably at risk and ones to keep an eye on for kind of developing the anxiety disorder over time. But just in general, this is probably consistent with the trajectory of anxiety disorders over time. Similar to depression is another one. It's got an even later kind of onset than anxiety disorders. It's really much more common in adolescence. That's also true for anxiety disorders. And we're seeing a bit of that pattern in kids on the spectrum as well for the anxiety following what we see in the traditional population, except that 30% of kids who aren't on the spectrum don't usually have anxiety disorders. So this is actually already escalated. There is at least one study I know out there that was reporting a very, very high rate of anxiety disorders in preschoolers or preschoolers into the school entry period. And in that study, they used a structured interview, which is the difference between the structured interviews and the semi-structured interviews. The structured interview, you just go through, and if a parent says yes to the question, then they have the symptom. The semi-structured interview, we do all this stuff I was talking about to be like, is it actually really that symptom? And is this anxiety or something else? In the structured interview, you get a huge, like 70% of the kids met criteria for an anxiety disorder in an autistic sample, but I would have a lot of, I would view that with a grain of salt, given the way that interview is done. And they're not really thinking about like all these other factors that might be at play. I think another thing that I'm really interested in is adversity and negative experiences and how that can contribute to the mental health of kids on the spectrum, both from a PTSD perspective, which is another area of my research, but more broadly in thinking about how those adversities might contribute to just broad mental health like the anxiety disorders. And that's another one, as you go through life, your list of adversities increases. And you're in more and more challenging environments, right, where the anxiety really can be brought up. Those are some of my thoughts.
have a question from Zoom.
Sure.
And then we can go back to the room if that's okay. Sorry, it's a little bit of a long one, so I'll read it. Great presentation, it says.
Thank you.
In terms of treatment/intervention, you mentioned CBT protocols and their effectiveness. I know there is research underway at CAMH on adapted delivery of acceptance and commitment therapy / training for autistic young adults, but it hasn't yet been published. Have you clinically or academically come across promising findings about the use of ACT protocols for the treatment of anxiety for autistic youth? Any thoughts on promising school-based anxiety intervention?
Well, I'll take the last part of that. In terms of promising school-based anxiety interventions, Judy Reven, who developed the Facing Your Fears program, which I think has been disseminated in different parts of Canada, including possibly here in Montreal, is developing a school-based version of that program where they're training school counselors and teachers directly in it. So that trial's going on right now. So I think that one's very, very promising. In terms of ACT and mindfulness, I think it's a great approach. I'm pretty sure that I've seen pilot research suggesting that there are advantages for kind of adolescents and adults. There's certainly some stuff suggesting, again, very pilot, that it's that mindfulness can be a useful approach. So from that perspective, I think it's very, very promising. And just in general, as a clinician, it's good to have multiple tools in your tool belt. Okay. I was hearing somebody kind of jumping on CBT a little bit the other day and being like, CBT doesn't work for everyone. I'm like, yeah, of course it doesn't. Like even outside of autism, CBT doesn't work for everybody. It doesn't jive with everybody, you know, and you want to think about what's a good fit. So from that perspective, I think it's really, really nice that things like ACT and mindfulness and DBT actually are now being considered in this population. So we have a variety of strategies to help kids with just emotion regulation. That being said, exposure can be a really critical part of anxiety treatment. That's different from general emotion regulation treatment. And sometimes that's really, really indicated. So you can't just talk about anxiety and calming yourself down with anxiety. You really need to work with kids to put using those skills in place to actually make changes to enhance that functioning in their life, to get back against that restriction that anxiety can lead to. If a treatment is missing that component, I think that there might be some questions there about its ability to achieve the same efficacy.
What's the name?
Judy Reven has a program called Facing Reven. Yeah, R-E-A-V-E-N. And her program is called Facing Your Fears. It's a group program, and she's done a lot of very strong research to examine it, and it's currently being adapted and tested in a large effectiveness study. So it's not just like research clinicians doing it. They're actually doing it in the schools where the research team teaches kind of the school folks to do it, and then they just go. So real life test currently in Colorado. So I think that's a really good one to keep an eye on. Yeah.
Question?
My question was basically that, but how would adaptive cognitive behavior therapy approach non-verbal individuals?
Yep.
Oh, sorry, I keep forgetting that. So sorry.
Sure. So the question was, how would an adaptive CBT approach work for nonverbal individuals? This is less my area, but for individuals who don't have language, it's actually been more of a behavioral approach and working very closely with parents. And the articles I'm aware of on that are Tamara Rosen did a review of kind of behavioral strategies for dealing with phobia in autistic kids that's out there. And then Audrey Blakely-Smith is working on an adaptation of Facing Your Fears for kids with intellectual disability. I don't know if how many kids have actually no language in that study, but she's trying to adapt it down.
Like a lot of our
Yes.
kids are very anxious. They can't really express
Mhm.
what is driving that anxiety.
Yeah. So I think Audrey Blakely-Smith is doing work with that group and adapting Facing Your Fears specifically for that population. There are a few published case studies out there. And then there's also, I think, some interesting work that's basically work on CBT for very young children who also oftentimes are not able to articulate. And there are CBT programs that are focused just on parents. So Eli Leibowitz's SPACE program is entirely focused on reducing accommodation, and it's an anxiety treatment for the child that goes only through the parent. They are just starting to look at this for kids on the spectrum. I think it's interesting, but I'm also going to just remind you all of my accommodation slide at the very beginning. And to suggest that it might be really, really complicated, and that research is not completed yet. But those are some places that I would look for. How do we work with a kid who really can't articulate exactly what they're feeling, but we think they're quite anxious? The other thing I would note is, like, when I first started doing CBT, I don't know, I had all these ideas about like how philosophical I needed to be, and like the cognitive restructuring, and I needed to be like a brilliant Socratic questioning kind of thing. And, you know, like with kids, sometimes the coping thought is like, I can do it. Go me, as opposed to like, I'm gonna die. And it can be, so you can think about matching like their developmental level. And sometimes it's about just getting more encouragement, support, and taking whatever step towards the anxious thing you can, as opposed to away from it, and rewarding that.
We have another question from Zoom. Amazing presentation. I'm going to include all the compliments on the presentation when I ask you a question. Yeah, definitely. Oh, full of learning for me. Are there any published articles or guidelines on discussing how the behavior of others affects the social anxiety of a high functioning autistic individual, and how they can interact to help the individual engage in social interactions with less anxiety?
Can you repeat that?
Maybe I went a little fast. Sorry. Oh, thank you so much. I was a little nervous. Are there any published articles or guidelines discussing how the behavior of others affects the social anxiety of a high-functioning autistic individual, and how they can interact to help the individual engage in social interactions with less anxiety?
Super interesting and great question. I don't know if I have a beautiful example for that. Here's the literature I am aware of. There are some interesting qualitative studies that are the accounts of autistic adults talking about kind of their experience of social anxiety and what's that like for them, and what are the things that kind of trigger them and how they try and cope. So I think that would be one place to start. There's also honestly a lot of interesting work going on in the folks who are interested in social skills and social skills training around not just imposing kind of neurotypical social skills on autistic people and trying to think about the ways that autistic individuals actually enjoy connecting with one another, and the ways that they connect, and valuing those things. So it's not a direct answer, and I don't know if they've made a specific connection to social anxiety yet, but I think that would be a very reasonable place to start. And that work in kind of understanding what are the preferred ways that autistic people like to hold friendships or interact with one another, and us understanding those, as opposed to kind of inflexibly requiring them to interact in a non-autistic way. I think that would probably get at the root of some of what you're asking. If that's been connected specifically with social anxiety yet, or targeted in treatment, I'm not sure, but it's a great illustration of why I think, again, thinking about these distinct anxiety presentations exactly raises this point, which is that in some of these cases, you're really going to want to think about that interaction of autism and anxiety before you just bulldoze into exposures, right? Even if you're still going to do the exposure, I think it makes a lot of sense to have that kind of understanding about what are all the facets going into this fear for the person that you're working with.
So when you're talking about PTSD, does it?
Oh,
Yeah, because we assume that maybe some of our students are having PTSD
Yeah.
versus anxiety. It's hard to know what the difference is between the two, and does it present itself differently in autism versus the anxiety?
okay. My PTSD talk is a whole other talk. Okay, yes.
That's similar to the anxiety.
Well, it came from the anxiety stuff for me.
Okay.
So it's very much inspired exactly everything that we've looked at in anxiety, because part of what you see in the PTSD research actually is that, in contrast to most other mental health conditions, there's actually not a lot of great data suggesting that there's an increased rate of PTSD in kids on the spectrum. Okay. In adults, you'll see a lot of studies saying, oh, it's PTSD, self-reported PTSD symptoms and autism symptoms are related, okay? But they're usually like online studies, self-report, there's a lot of issues. In kids on the spectrum where they've assessed for PTSD using like structured interviews or semi-structured interviews, there's not necessarily a clear pattern of an increased rate, and that's kind of weird, to be honest. Because we know that kids on the spectrum, kids with developmental disabilities in general, are absolutely at increased risk for all different types of maltreatment. And we know that there are a variety of things that kids on the spectrum are likely going to be exposed to, even, you know, when all the best intentions are there in terms of restraint, hospitalizations, having to be removed from their families at times, like this stuff happens. Anybody who works with this population knows that this happens, and yet there's been a real dearth of research into PTSD in this population, and there's not even clear evidence that there's an elevated rate. There's a really interesting study by Brenner, actually, that looked at the autism inpatient collection across the US. And there was a notable rate of kids who actually had an abuse history. And the rate of PTSD was maybe like 3%. Even 30% of the kids had a maltreatment history, and PTSD was only marked by the clinicians in about 3% of them. But when you looked at actual traumatic stress symptoms, there was a lot more there. So there's a lot of reasons to think that just the way the PTSD criteria are written, they may not be sensitive enough for this population. There's a good precedent for that. If you think about that, those criteria actually had to be adjusted for young children already, because originally they weren't sensitive enough for young children. And based on all this work I've done in anxiety, I think there's also reason to think, and we have some data suggesting now, that there might be distinct expressions of PTSD in this group as well. So things you have to look for. I went on a total tangent there because you got me on my other interest. And I forget what the original, how do you differentiate it from anxiety? PTSD, if you can identify what the event was or the traumatic experience, is going to be usually associated with really significant change in functioning. And one of the clearest ways to differentiate PTSD from other mental health conditions, which also, by the way, can be a traumatic reaction. So for a lot of kids, the traumatic reaction is not actually PTSD, it's developing an anxiety disorder or depression. Okay. But something that's really different about PTSD is the traumatic memory and the avoidance of trauma triggers. And that's where the PTSD treatment is also different than anxiety treatment, because you actually have to go after that memory. And the way that those triggers are basically bringing it up. The past is not past in PTSD, basically.
The fire alarm, could that be a PTSD?
So in the trauma, I can come back and give you all a trauma talk. So we've taken kind of a mixed method approach to also trying to think about like what are the sources of trauma for kids on the spectrum. And one thing that comes up a lot from clinicians, from autistic individuals, and from parents are things like a haircut, okay? A shot, going to the doctor, being held down, a fire alarm, etc. So it is possible that there could be PTSD there. It's also possible that the traumatic reaction is a horribly impairing phobia. Right. So yeah, because that wouldn't be uncommon either. Sometimes kids, the most common reaction actually after trauma is often sometimes anxiety or depression as opposed to PTSD. So okay, that was a very long-winded answer. I'm sorry.
All right, another one from Zoom. Love the presentation. I learned a lot. Thank you for addressing the limitations of the study. Is there any literature that explores gender differences in the presentation of anxiety? Additionally, is there any work on the cultural responsiveness of the assessments/intervention currently being used in this area?
Cultural responsiveness, I think that is a work in progress. Although people are like attuned to this is a problem now and working on it. But what was I going to say? In terms of gender differences, Dr. Christine Nordahl at Mind Institute has the GAIN study. This is a specific cohort of girls on the spectrum that they are following longitudinally. And she is specifically looking for not only differences in the presentation of anxiety, but differences in their neurobiology that might be related to these different presentations. So I think that would be a study to really keep an eye on. Back in the day, like in the 2010-12 review that I said, this is where it all began. we weren't really seeing gender differences in anxiety disorders for kids on the spectrum. And in the general population, you often don't see huge gender differences until puberty. And then after puberty, you see a lot more girls, but early on, not necessarily. More recently, there are studies suggesting there might be more anxiety in girls in particular. So I think that's something that you can definitely look for. We're also seeing a big change in how autism is conceptualized and more girls getting detected, which could influence changes in these rates as well. So that's how I would answer that question. I had a graduate student recently suggest to me that they should do a review on kind of cultural competence within the context of CBT and autism interventions. And I was like, that's a great idea. And so I will tell them that somebody actually asked about that today too, which is another indication that it's a great idea. But I don't know of anything that's specifically done that yet.
The prevalence of anxiety disorder.
Yeah.
You just over time, I know there was like a lot of ranges. But
Yeah.
I've seen it's increasing and how that compares to just the general.
Yes.
So the question is about the prevalence of anxiety disorder in youth developmentally over time, if I'm correct.
Yeah. So I think it mirrors the pattern that we see in non-autistic youth, which is that the rate of the prevalence of anxiety disorders likely increases over time. I think there's a little bit of inconsistency if you're actually going to see the biggest rates in teenagers versus adults. And that probably has to do with what age adults you're looking at as well, because different periods of development can be stressful in different ways. And usually transitioning to young adulthood is quite a stressful time. It's also associated with a big drop in services for a lot of youth that can be a real stressor, and then it's associated with a lot of anxiety and depression. But in general, you see a similar trajectory in autistic and non-autistic of just growth over time. So we'll see more anxiety disorders in school age kids than preschoolers. We'll see more in adolescents. And we often see kind of the most, I mean, some epidemiological studies of adults are, putting rates of comorbidity at like 80%, and the anxiety disorders in the 50 to 60% range. Those are epidemiological studies, not my tailored, nuanced interview where we're trying to be really careful. So you have to take it with a grain of salt. But in general, that's the trajectory, with one difference is that everything's higher. So we're seeing more at preschool than we do in non-autistic kids, and even more in school age. So the trajectory is similar, but you're probably starting at different places. Yeah.
Sure. So I remember in your kind of the context of your presentation, you were discussing the effectiveness of an autism adapted CBT program versus a standard one. And I'm curious, what does that what does an autism adapted CBT program look like?
Yeah.
How is it different from standard one?
Okay, great question. And I kind of glossed over it because I already talked for over an hour. So yeah. But I would say the adapted programs kind of fall into two camps. One would be kind of modified programs where you take a classic CBT and you're just trying to make it more accessible for a kid on the spectrum by using more visual cues, by integrating their focused interests, by involving parents more. The involvement of parents has been one of the most consistent things across the research studies associated with better outcomes in terms of just helping kids generalize their skills and get further with the exposures. And then the other category of adapted program, which is the BIACA program, which is what I presented, that had kind of the even better outcomes than just plain CBT. That is where they're actually also providing, for example, social skill support. So it's a modular program, and the clinician is able to pick the modules that they think are kind of the best fit for the child. So there will be actual whole social coaching modules that for some kids will get integrated with social exposures. To support them. There might be an entire module around behavior management for some kids where that is a challenge as well. So it's in some ways actually a more encompassing program that is looking at not only the anxiety, but the things that can sometimes go with anxiety for kids on the spectrum. So that's the difference, I'd say, between like a BIACA, which is that more encompassing modular approach, versus something like Facing Your Fears, which also has really good efficacy, but is a really focused on the anxiety. But trying to teach kids about anxiety and how to face those fears in a more accessible way, given that they're on the spectrum.
Okay, so if you don't have any questions, before we get going, I just want to say thank you so much, Dr. Kerns, for your wonderful talk. Thank you also so much, Giant Steps, for hosting us. Before you go, we have a sign-in sheet that maybe on your way out you can sign, but thank you so much for your time. I so appreciate it.
Thank you, everybody.
Thank you.